I'd like to welcome Dr. Linnea Linde-Krieger, Assistant Professor in the Department of Family and Community Medicine, to present Principles of Trauma-Informed Care and Practice to the Drug Policy Research and Advocacy Board at our meeting on September 5th, 2023.
So I'm going to give a couple definitions of trauma, not because I don't think you know what it is, but because it is diverse and multifaceted, and there are many different definitions out there. So our DSM-5, our Diagnostic and Statistical Manual, sort of our Bible of treatment, categorizes trauma this way. So first of all, trauma is an exposure to a serious event, and it has to be a threatened death, a serious injury, or sexual violence. So there has to be an exposure, right? So trauma is an event that happens in the environment. Interestingly, the DSM does not consider something that's not threatened death or harm to be a trauma. So things like loss, divorce, neglect are not necessarily considered trauma from our DSM definition, which is a little bit limiting. And so the DSM also emphasizes that trauma is not only an event or an exposure, it is also a reaction from the individual. So extreme stress that overwhelms coping capacity. So both an exposure and a physiological or emotional response of the person. I think SAMHSA has a better definition, personally. I think this one is a little bit more holistic, and it's really considered a framework for understanding the complex nature of trauma. So SAMHSA came up with this framework, this definition, with a focus group of researchers, practitioners, people with lived experience of trauma, their family members, right? So it's a little bit broader and more holistic. So SAMHSA says that trauma results from events that are experienced by people as emotionally or physically harmful, and that may have these lasting adverse effects on well-being. And so this definition really emphasizes what SAMHSA calls the 3 E's of trauma. So first, we have that exposure or the event, right? Trauma has to happen. It has to be something that happens in the environment. It doesn't have to necessarily be identifiable, though. And we see this often with things like early childhood trauma, traumatic events that maybe are not accessible to memory. So that is an important point. So there has to be an event, but you don't necessarily always know what that event is. Then beyond event, it is a subjective experience of trauma that really varies from person to person. So multiple people can experience the same event, and to some that will be traumatic or it will overwhelm their ability to cope, and to others, it may not be a traumatic event. And then SAMHSA also recognizes and emphasizes the lasting effect of trauma. So sometimes we have really acute trauma effects, and sometimes these effects last for a long time. Sometimes they don't show up right away. So that's sort of the elements: exposure in the environment, subjective response of the individual, and then these effects that can be long lasting. So I'm definitely not going to talk about all of these potential traumatic events. I just like to highlight that these are considered PTEs, potentially traumatic events, because to some people, these events will feel traumatic. They will overwhelm the person's ability to cope with the situation. And to other people, they will not overwhelm that coping ability and may not lead to long-lasting effects. So trauma can be caused by effects, again, that people don't remember, that they can't identify. Trauma can be caused by events that are really well-intentioned, things like maybe a medical procedure, right, that are supposed to be helpful and well-intentioned, but can have lasting negative effects. Trauma can result from an event maybe that didn't happen to an individual, but that happened to a group of individuals. So cultural trauma, things like slavery, the Holocaust. So not necessarily just individualistic events, but broader events and historical traumas too. Many people experience more than one traumatic event, and we know that trauma has cumulative effects. So in order to be trauma-informed, I will get to trauma-informed very soon here, but in order to be trauma-informed, one of the key components is to understand the widespread effects of trauma. And so trauma really is pervasive, both in our US society and worldwide. So we know that more likely than not, individuals have experienced a potentially traumatic event in their lifetimes. Up to 20% of people who experience one of those potentially traumatic events may develop long-lasting symptoms such as PTSD or post-traumatic stress responses. But interestingly, and this really speaks to resilience, that means that 80% or more of people who experience PTEs do not go on to develop long-lasting traumatic stress effects. And so recovery and resilience are not only possible, they are probable and they are the norm. So we'll come back to that sort of resilience perspective in a little bit here. Certain events, certain potentially traumatic events have a much higher likelihood of long-lasting negative trauma effects. And so we see things like interpersonal traumas. We sometimes call them betrayal traumas. So traumas that are intentionally caused by a person that was meant to care for you and to protect you. Those tend to have worse lasting effects and more likely to cause PTSD symptoms. And then early childhood trauma. So early childhood trauma is particularly important. So trauma can really be a developmental disorder. And so I'm sure everyone here has heard of adverse childhood experiences and how those in particular can have a long-lasting effect of both physical health and well-being and emotional health. So again, most people, the majority of people, have experienced at least one adverse childhood experience of maltreatment or household challenge. And then about 16%, 1 in 6% of people have experienced 4 or more ACEs before the age of 18. And that is really that 4 number. There's something important about that. That's in the research is really considered a tipping point for individuals who have experienced more than 4 ACEs or traumatic events are more likely to experience PTSD and lasting effects. So I'm going to give just a couple really basic assumptions about trauma that I'm hoping can help us think about trauma responses and how we should address them as care providers in a trauma-informed system. So first, trauma really impacts memory and integration. So when someone experiences a trauma that overwhelms their ability to cope, we also see that as separate from normal experience and normal integrative abilities. And so traumatic experiences are often split off from normal functioning, and that is really protective. That's a really good thing at the time of the trauma. So probably everyone has heard about fight, flight, freeze responses, which at the time of trauma, those are survival responses. Those are really, really important. But when those responses keep happening in everyday life, when it becomes ingrained, that's where we start to see really negative effects. And so even when traumatic experiences are not at top of mind or accessible to our conscious experience, they have a really strong ability to shape our functioning, our behavior, our well-being, how we feel. So what we often see for an individual in particular who has experienced cumulative traumas or is really struggling with traumatic stress symptoms is that there's sort of 2 tracks of functioning. So most often, individuals, even with severe traumatic experiences, can function normally, can function as if the trauma never happened. And so this is what we might think of as a grounded space or a safe or a typical sort of adaptive space that the individual is in. And that is also very protective, right? So this ability to avoid the traumatic memories and the traumatic triggers is very protective. However, the other track, I really liked how Lauren called this sort of the activated track. Some people may call this a triggered state of being, is when the individual functions as if the trauma is still occurring. And as service providers, as loved ones of people who have experienced trauma, and as individuals ourselves who have experienced trauma, this can be frightening and confusing, right? So often that activation occurs and we don't know what's happened to us. We don't necessarily connect that to the traumatic event that's occurred, and it really changes behavior. And so in the traditional model of treatment that tends to be more punitive, these behaviors are looked at as negative functioning or bad behavior, right? But they are often outside the control of the individual and quite frightening and confusing. So moving into trauma-informed, once again, there are many different definitions. I'm going to give you a Samson one that I also like and that is very oriented to organizations and systems, because I know that's what you're building here. So a trauma-informed system is one that first realizes the prevalence and the impact of trauma, and also has some understanding of potential paths for healing through trauma. A trauma-informed system can recognize those signs and symptoms of when somebody switches from that typical functioning, that adaptive or grounded functioning, into that more activated functioning. So recognizing what that is. That's not resistance. It's not an anger problem. It's not a borderline personality disorder. It is a trauma response that has helped this person survive. And so that's really important at the individual level to recognize, and also at a systems level, that systems can also be infused by trauma, right? And so when we see a system behaving in a way that we think maybe is odd or bad, being a trauma-informed approach allows us to take a step back and say, why? Why is this system or this individual functioning in this way? And a trauma-informed system also responds by integrating knowledge about trauma into across the organization of policy, their practices, their settings. So not just the treatment provider or the clinician with the patient or client, but across the entire system. So first and foremost, trauma-informed care aims to avoid re-traumatizing individuals in the system, staffs, patients, everyone who's involved in the system, and recognizes that some of these traditional models of treatment are in themselves re-traumatizing. Sometimes these really punitive or controlling treatment approaches can feel a lot like the trauma and can create that place of activation, both in clients and in staff members. A trauma-informed care recognizes that all of these negative or bad behaviors really are coping skills that come from that place of survival and adaptation, and that it's important to recognize how and why those behaviors have worked and honor those behaviors and how they have worked in order to be able to allow changes and new skills and better regulation. A trauma-informed care strives to maximize choice. So we'll talk a lot about that in just a minute here, but this idea of collaboration and choice for the individual, and recognizing the individual patient as the expert in what they need in their own lives and in what treatment is going to work for them. And trauma-informed care is culturally competent and curious about the individual's response to trauma and what they want for healing. So we know often that the context of trauma and the effects of trauma are very much culturally based. And if we can't understand that and where and why the responses are coming from, we're not going to be able to help address those. Trauma-informed care is not a treatment strategy. So trauma-informed care does not equal trauma therapy. Every single individual working in a system can be trauma-informed and can provide trauma-informed care, from the front desk staff all the way up to executive leadership. It is an orientation. It is a way of thinking about practice and about operating a system rather than a particular type of treatment. And trauma-informed care is not just a fad or a trend approach. Unfortunately, I had somebody say to me recently that, gosh, what did they say? That adverse childhood experiences were really hot a few years ago, but not so much anymore in terms of the research. And I'm like, oh no, these things are pervasive and they affect how we function, how individuals function, how systems function. And that's not going to go away until we really recognize how to address that. So I wanted to think about, from a systems perspective, what the shift to trauma-informed may look like. So first and foremost, trauma-informed care is collaborative and it is relational. It is about how we are building relationships with our clients and with our colleagues. And so in a traditional system of care, I'm thinking in particular about substance misuse treatment, SUD treatment, there tended to be this sense of what's wrong with you? Why are you behaving this way, right? And we need to stop these behaviors. And so the trauma-informed approach really makes that shift from saying, what is wrong with you, to what has happened to you, right? And it's just a paradigm shift. I'm sure many of you have heard this sort of classic shift. And when we start saying, what happened to you? What is it that has led you to the place where you are right now? We're really able to focus more on strengths rather than deficit. We are able to partner with that client or that patient and recognize and respect their expertise. And in the more trauma-informed space, we really recognize the importance of healing within relationships. I want to go even beyond that. So trauma-informed care has been has really been well researched, probably for about 15 years now. I've been doing trauma-informed care and trauma intervention research for over 10 years now, and really we're kind of on the cutting edge of something different here, of an even bigger paradigm shift. And so we'll talk a little bit about that. So in this traditional treatment space of what is wrong with you, we see these practices that are re-traumatizing to our clients and our patients. So these ideas that some people just don't care and they're not working hard enough and maybe they're bad, right? And so these ideas can really permeate treatment and can be very damaging to both the staff and providers and to the clients. So the trauma-informed shift helps us recognize the things that people have gone through. This idea that people are really struggling, people may be suffering, they need effective treatment, providers want to help, they care, but they don't have the understanding that they need, and we need to provide that education around trauma and trauma-informed support. And that we also need to understand these pervasive effects of how trauma impacts development and behavior across the life course. And so then even further now, we're now moving towards this resilience-informed approach. And I really think that the trauma-informed and the resilience-informed approaches go hand in hand, and we can work with them together. And so in the resilience-informed approach, we shift that paradigm to say not just what happened to you, but what's right with you? What is going good for you? What are your strengths? And it's this idea that people more often than not are resilient. Resilience is the norm. Almost everyone has experienced a potentially traumatic event. Not everyone has these long-lasting effects, and that means something right is going on, that healing is not only possible, but it is the norm, it is probable. The resilience-informed approach strongly believes in the integrity and the rights of the individual, and that everyone deserves compassion and respect as they grow and they develop the new skills and learn self-regulation that maybe was lacking, especially when we're talking about developmental trauma. And that we as providers need to learn how to support people's strengths even as they co-occur with challenges. So this is the idea that it's not that someone is resilient or not resilient, it's that we may be resilient in some areas. We may be functioning and coping very well in some areas, but we still may be challenged and struggling in other areas. And the ability to hold those two things together as truths can really support healing. So when we think about a trauma and a resilience-informed approach, there are several key principles. Beth, tell me if I'm out of time here. I'll move kind of quickly.
You're great, because we started late, so you're great, Linnea.
So first and foremost, the foundational principles for trauma-informed approach are these, and safety I put at the top of the list. So if someone does not feel safe, staff and clients alike, if someone does not feel safe, they are not going to be able to function optimally. They're not going to be able to address whatever concerns or things that they're struggling with, whether that's the trauma itself, whether that's mental health in another area, whether that's substance misuse. Safety is primary. Resilience, again, so being able to look at strengths. So often when we look only at what's going wrong, or even what has happened to a person, what has gone wrong in the past for that individual, that feels very deficit-based, right? And so we want to be able to look at what's going right as well. At an organizational level and within dyadic or interpersonal relationships, trustworthiness and transparency are key to being trauma-informed. So this, at the organizational level, we want operations to be transparent, clear, no surprises for clients or for staff. We want to see that there's trust among staff members, that staff members are supporting one another and have access to their own, treatment needs. And that we allow outside influence as an organization. So letting the advocates, letting the DPRAB, letting people come in and make suggestions and being open rather than closed really helps with practice change and with being able to build a trauma-informed system. Collaboration and inclusivity are very important. So this is about respecting the client or the patient as the expert in their own life and really trying to partner with that person to develop the correct treatment plan for them. And then voice and choice. So the individual, having this person-centered, individualized approach is really key for trauma. There is no one size fits all. I'm sure everyone who's worked in these spaces really recognizes that, and that takes more time and that takes more work, but it's where we see the results. So we often say, I'm sure all the social workers here will have heard this one before, that people are hurt in relationships, right? Most often the worst hurt comes from those betrayals in those relationships, whether it's with professionals, whether it's with family members, and healing also happens in relationships. And so that trauma-informed systems are relational and recognize the power of relationships. What can we do as professionals? So definitely look for strengths and for areas of resilience and balance those with challenges, right? And look at how even the things that appear to be challenges right now serve a purpose, had a place, are adaptive, right? And recognizing even the negative behaviors as strengths that have really served the individual or the system, if you're working in the system. Promoting safety is key. So that means a safe environment physically. It means safe emotional and physical boundaries with clients and patients. It means not pushing people past their safe places and waiting until they are ready and they indicate they are ready to work on the trauma or other issues, whatever their challenges are. Again, as an organization, being open to these outside parties, the advocacies, the consultants, being open to change in order to create a better system and really addressing ongoing risk to safety at all times. Thinking about service provision. So are they correct? Are they the right services? Are they the services that my client wants? And if the answer is no, what can the system do to provide the correct services and the desired services for the client? And then maybe I'll end on this one. I wanted to put this on. This is sort of a framework for how to think about safety when you are building a trauma-informed system. So the different aspects of safety and how safety is both individual and systemic.